Hi there, OCD family community. If you've been around for the past few weeks, you know May is the month of amazing panels. And today is no exception, because we're following up with our PANS and PANDAS panel for a second discussion about this important OC-related disorder. So join the conversation, because today is all about your Q&As. I'm Nicole Morris,
Okay,
licensed
ma'am.
marriage and family
Okay.
therapist.
So,
and mental
welcome
health
back to our
correspondent.
family
I will
time.
be the
I'm so
first
glad
to
you're
say,
able to join us
welcome
today
to the family.
because we're talking
The
more
OCD
about
family, that
PANS
is.
and
I
PANDAS
am here
and
to create
related
a community
issues.
of
And if
support
these
for family
acronyms sound
members,
very new
spouses,
to you,
partners,
I'll mention it a
parents,
bit
adult
later in our
children as their
talk,
baby
but I will
adult
encourage you
words,
to take a moment
and chosen family
pause,
of
and
OCD
listen to
sufferers
part
and their
one of this
community.
discussion
I've
from
had over
last
22
fall
years
of
of
season
experience
2,
in the mental health
episode
field, but please
67,
note
because
that
there's
this
a lot
information
of
does not
foundational
qualify
info we
or
covered in
substitute
that
as a
chat,
diagnostic
and today's
evaluation,
conversation is
therapy,
really a
or
springboard
treatment,
from that
and it is
first
presented
panel.
on an
Also,
as-is
I'll note
basis.
that we're going to talk
Please
about
follow
some
up with a
emerging
qualified
research later
mental
in
health
our
provider in
discussion,
your
which
area
we're
regarding
fortunate to have
concerns for
Diana
yourself
Pullman
or loved
explain
ones.
a bit further.
Thank you for
And you'll
joining
hear
us
her
today.
referencing slides
Now,
and data coming
let's
out
get
of Columbia
started.
University. So since this is still in the works to be published, I cannot publish this data or these slides directly to you, fam. But I can direct you to Columbia University's research if you're interested in knowing more. And even without seeing what we are seeing, Diana does such a great job of explaining some of the variances and markers that we're starting to see for identifying PANS and/or PANDAS kiddos. So I'm excited that we get to share some preliminary findings for now, and I can't wait to see what happens with this research over time. Also, we're going to be talking about tics, Sydenham chorea, and even sensory motor or Tourettic OCD. And fam, this is so timely because we just wrapped up back-to-back sensory panels where we went further in depth about tics, Tourette's syndrome, Tourettic OCD, Just Right OCD, you name it. So if you haven't heard those panels and you're like, what? Tourettic OCD? Check out those episodes. That's season 2, episode 91 and 92. I will link them also on this episode's blog over at ocdfamilypodcast.com. Because having that context for what we mean when we say Tourettic OCD will also be very helpful in explaining what we're talking about. Lastly, I'm going to jump right in with our panelists because they're going to do a little brief how do you do reintroduction. Because again, we go more in depth on all of this in episode 67. And we have so much to discuss that we don't want to waste a minute of time. Thanks everybody for coming back. So I'll start with you, Diana, if you want to do a little reintroduction of yourself.
Hi, I'm Diana Pullman, Executive Director of Pandas Network, and I am based in California.
Hi there, I'm Angela Henry, and I'm the director and founder of the Center for Collaborative Healing in South Bend, Indiana, working in private practice with kids with OCD, anxiety, Tourette's, and lots of other PANS, PANDAS challenges, etc.
Hi, I am Lindsay Forsyth. I am a mother of 2 PANDAS patients, and we have quite a group here in the Northwest Indiana area of families that really organically have come together and support one another. And so as a result, I have had the privilege of learning a lot from not only our lived experience, but also the experiences of other people whose kids have different types of symptoms and flares from mine. And it's just taught me a whole lot about not only the disease itself, but what families go through when they're trying to navigate the whole process from start to hopefully remission.
Excellent. And we are missing Brittany today. She sends her love to the fam here, but Brittany is off on a fabulous adventure to the DR. And I say, hey, next time we have a panel, I say we go to the DR. I'm for that, Brittany. You're onto something there. So welcome back to the OCD Family Podcast. And for anybody joining us, if you are unfamiliar with PANS, PANDAS, Lyme, we're going to be discussing all of that and more, Bartonella, mold, all of the things. I would encourage you to go back, pause here, and listen to our first episode that happened during our OCD related disorder series. All of that information is going to be linked in the blog over at ocdfamilypodcast.com. Do check that out. And so we've collected from across the internet different questions. We've had some in just previewing the questions. We've had some lived experience folks speaking, but also a lot of parents and caregivers talking about some of the common questions, concerns that they had. And really, when we wrapped up our panel last time, Lindsay, something you said really stuck with me of parents in the trenches
It is so
Mm.
hard, and it can mean so many different things, and you can really see that illustrated in just the variety of questions we received as well. And so this episode is really a Q&A time for us to be able to talk. Diana, we are very fortunate to have you because you really have your finger on the pulse of what's happening policy-wise, advocacy-wise, what the doctors are saying, who's getting it, who's not.
Well, I don't know about all that, but I'll try.
She's like, "Those are big shoes, but I would agree. What are you ladies?" And the rest of the panel is like,
Okay.
we're all
All the
like,
research. Yeah.
yes, exactly. We have Angela, who is just a pro in treating this and such an asset to our field. We have Lindsay, who's been such a fierce advocate. And part of the reason we have that Northwest Indiana coalition that's really developed is because of people like Lindsay that have not only done everything for their kids, but for other children out there suffering. And so it's so incredible, just the power of a mom. We have that with
Yep.
Diana too. Diana has a lived
Yep.
experience mother of pandas kiddos. And so we are so fortunate to have you all back with us today. So we have some questions. We have lots of information. Make yourself cozy, fam, and we're going to go ahead and dive right into it. The first question is this. So someone shared they were perfectly normal, just living as a freshman in college when suddenly they had an onset of agoraphobia, emetophobia, etc. They would get scared to the point they thought maybe they would even stop breathing if they left the house at times. Friends and family couldn't understand the change. And the rational
Mm.
part of this person's brain literally, like, they were like, I know this doesn't make sense, but I can't help but to think it. It was very awful. We saw a sudden onset of tics, of POTS, which those of you that are not familiar with POTS is really when you have these orthostatic changes in blood pressure. You might feel dizzy or near syncope, near faint. Also, mast cell activation syndrome, and I've seen this come up over a course of a number of questions. So you guys will know more about that. I'm like, I don't even know what that is. And this person says a big boo to that. So they did have a history of PANS and PANDAS that occurred after Lyme disease, Bartonella, and I don't know this one, if you guys know the pronunciation.
Babesia.
Babesia. Yes. Okay. Diana's like, yeah, I know. See, Diana, you are the wealth of knowledge.
I sat around at a lot of coffee tables.
And that's why you're here at our coffee table. We are so, so grateful for it. And so they're noticing it comes on in flares. Sometimes they're perfectly fine leaving the house. Other times, again, they get into this, I can't breathe if I leave my bed. It's very frustrating.
Terrible.
And they're asking about IVIG. And so this is something we've talked about a couple times, but if we can just reorient people, what is IVIG? What is the usefulness when it comes to PANS and PANDAS? And we'll just start there.
Okay. IVIG, intravenous immunoglobulin. So I love IVIG. It's used widely in many hospitals, hundreds of times a day. It is healthy T cells. Those are healthy cells that fight infection. It's a product that is infused into a person's arm and it calms down misbehaving when your body is having an anaphylactic reaction or overactive immune cells. When you have an anaphylactic reaction or an extreme reaction to something autoimmune wise, your body overreacts and you get bad inflammatory processes. So IVIG is non-alarmed T cells that calms down the bad actors in your own body. And it's also used for when people have very bad infections from whatever in the hospital, or they fall and get a bad cut on their leg. IVIG can be used to deliver healthy T cells that heal the body quickly.
Interesting. So it almost reminds me of like transplant kind of functionality where we're putting in this healthy system to kind of help with the override of gunk that's been happening.
Right. The parents, we just donated money to have a study of what does IVIG do in pandas children's blood. And we discovered that this will be published in June. It's out of Australia. We gave the money to the University of Sydney, Australia. They discovered that it actually calms down all the RNA. You have DNA and RNA. RNA goes out and signals everything and tells the body what to do. They were able to measure people's RNA when they got IVIG, and they found that all of the cells and their RNA calmed down and became orderly and organized and balanced. So IVIG is literally going directly into your DNA pretty much, and correcting things that are out of whack. Isn't that cool?
Yeah, it is cool. Lindsay, what are you going to add?
Was going to say from a, perspective of outside of the science, I get this question a lot from the parents, and I know Diana does as well. It's a scary thought to some people because it's unfamiliar. And I was one of the people that dragged my feet for a good bit before we decided to pull the trigger on it. And I think ultimately, this is where your clinician can help you through what that looks like. But the only regret that I have in our IVIG journey is not having done it sooner, because it is the single most important factor as it stood alone in helping my child to heal. We had done tonsillectomy and adenoidectomy, knowing that that probably wasn't going to be, quote, healing him. It was just basically to reduce the incidence of strep because he had so much strep going on that we actually never really knew because he never had symptoms of strep. A lot of these kids do not get typical symptoms. So for me, I was dragging my feet quite a bit. I did the tonsillectomy and adenoidectomy. We'd done antibiotics. We were very vigilant about triggers. And he said that he was at an 8 out of 10 in severity. His OCD was a lot of fear-driven. Bad things are going to happen to me. Things have to be just right or the world is going to crumble. And a lot of arm and leg movements that made it almost impossible to sleep. And after IVIG, you will typically see that there will be 2 steps forward, 1 step back. You might see glimmers of your kid on day 14, and then, they might have another flare. It's not like a quick magic bullet in terms of 2 days later, you're going to be completely remitted. And some people will take more than 1 round, but it moved the needle in our experience. He said that he was in the high 7s, 8s, and he said about 12 weeks later he was down to a 2 or a 3 out of 10, and he was
Now,
sleeping well.
that's what I saw with my 2 children as well.
Yeah. Hey, Angie, I have a question since you're treating tics, and it just made me think of it as Lindsay was talking about those tics that were really disruptive at nighttime. Is there a connection that we understand or something exacerbates the premonitory urges that can be experienced within tic disorders or Tourette's? And does that get calmed down in the same way? Because we know environmental things can make such an impact when it comes to tic disorders. And so I'm wondering if it's just that added stress from inflammation, et cetera, that makes that premonitory urge more strong. Would love it if you could speak to that.
Yeah, actually, you're spot on with that, because part of when I'm treating tic disorders, one of the things is what are the triggers? What makes this tic present itself? What makes it better? What makes it worse? And so we're looking at those environmental factors to kind of bring down things that are happening so that the tic might not present as much. And yeah, if your brain is inflamed and you're having all this anxiety, you're having just overload in terms of your nervous system, that's going to increase
Yeah.
all that anxiety, everything that comes along with the PANS, PANDAS. That's just a ripe situation for you to have emotional dysregulation challenges that's going to perpetuate more challenges with the tics.
Yeah, that's a good point. And I will just point listeners, if you are newer to tics, and I will just show my ignorance in really starting to learn more about this, but I just had a sensory panel on the podcast, and we heard from Dr. Max Mazel in terms of learning more about those premonitory urges and all that can entail, as well as Tourette OCD. And that's some of what we could see showing up, as well as just right OCD for some of our PANDAS and PANS kiddos. So I think that's something worth referencing. Any other thoughts before we move on?
My son is 24, so he was one of the first PANDAS kids at 7. And he asked me this exact question, I think is what you guys were just saying. He said, so when I was a kid and I had these urges to do strange movements, he said, is that the same thing as Sydenham chorea or involuntary movements that you see body movements in Sydenham chorea? So that's a strep sequela thing. Are the PANDAS kids having compulsions, the desire to move? Is that a tic? Or is the big body movements that happens with chorea a tic? What is it? And I said, they're separate, but it's really difficult to pull that apart with a young child. Since we're talking about PANDAS and PANS, is it truly from the immune process or is it an OCD kind of urge? both autoimmune and mental. I don't know. But in Sydenham, Korea, they cannot stop their
Yeah.
movement. It's not a compulsion.
Honest to goodness, right before we did this podcast, I had a family, Lindsay, I think you're familiar with, that was actually sitting with me, and the gal's in a flare. And I had never seen her tick before because I've never seen her when she's in a flare. And so it was so interesting. And the tick, I asked the mom, because the mom is in the medical field and just really well versed in all of this too. I said, is that Sydenham chorea or is that a tick that's happening? And so she was able to say, like, the Sydenham chorea is where it's much more fluid, much more
It's like a snake. It's
usually
very snake-like.
we agreed that it kind of looks like amoeba-ish, like
Yeah.
fluid here. Whereas the ticks are very much more prominent, much more fast, more jerky kind of movements. It was just so interesting to see that inside an actual flare for this client.
Oh, well,
Different.
she needs some medical treatment.
Yeah, I think they're kind of starting on that. But
Yeah.
then Lindsay, with your guy, you were able to kind of look at his leg movements, I believe, as Tourette OCD kind of movement happening as well. Is that?
Yeah, I was just going to say that you really helped me understand that better, Angie, when I would ask you questions about it, because I had the same, I mean, like, literally the way that these last comments panned out, it's perfect because the question that Diana brought up is exactly the question that I asked Angie about how to tell the difference between an involuntary tic and Tourette OCD, which I did not know was a thing. And I'll tell you, the reason that I brought it up was because our first neurologist put us on guanfacine to help with Brady's tics, and the guanfacine did not work at all. And Brady basically saw no benefit in it. And I said to our PANDAS specialist, who's not our neurologist, that the guanfacine didn't work. And he's like, of course it didn't work because it's a form of OCD. It's not a neurological tic. And I was like, oh, wow. So that's when I asked Angie about it. And what I think is really important about that is that CBT or whatever we did with our therapist was very, very helpful because it helped us through the flares and helped our son to manage his various forms of OCD during a flare. So he didn't feel completely out of control, completely at the mercy of whatever trigger flared him. It was a great way to keep our head above water while we address the inflammation that caused it. Because as we address the inflammation, back to the point about IVIG and like actual clinical therapies, when that inflammation goes down, clinicians and parents will tell you, so will the symptoms. So the cognitive behavioral side of things, or the therapies that you can do to address the OCD and the Tourette OCD with a therapist, does help so much conjointly or concurrently with actually addressing the physical side of things.
Yeah. And I think that I'm seeing young people now with all this talk about mental health and anxiety. It's becoming more open in society, that it gives people a sense of power. I hadn't thought about that. It's kind of what you're saying. If you can name it and say, hey,
Oh my
this
God.
is what it is, then you can
Yeah.
figure out how
That's
to,
why a
help
diagnosis
with it.
matters.
Yeah.
Yeah.
And it's really neat. Like I'm seeing it with my children now that are older. Yeah. CBT is really powerful for occasional use of distress.
Yeah, occasionally. Yeah. Well, and even when distress gets really high, but what I would also say is it's so nuanced, right, Angie, when we're looking at treatment from the spectrum of OCD to Tourette's syndrome. And again, I credit Dr. Max Mazel, who helped me really unpack this a little more. And so if the fam is just kind of like, but what is that? Again, I'll refer you back to our sensory panel. But what I will say is, even for a very well-learned OCD specialist out there, not all of them are going to understand Tourette OCD as well as tics. And so one of the things, Angie, if parents are out there looking for a provider, as a provider that also treats tic disorders, can you give some recommendations even in how to ask or what to ask when evaluating, is this going to be a good therapeutic fit? Sometimes people feel like they don't even have the choice because they're like, there's one person that allegedly treats it, so that's where I'm going. But in terms of, and Diana, your laughter shows me like, yes, yep, right? But Angie, what would you recommend in terms of something that a parent or a caregiver could ask to be able to know whether their person
understands tics, or maybe should even partner with somebody that specializes in tics?
Yeah. So I would say sometimes these people are unicorns who treat all these different things. And that's kind of why, like in our own little OCD groups, I'll often talk like if you have worked with OCD and you work with kids, you probably work with PANS and PANDAS and may not have even known it. But oftentimes I'll see, I don't know about you, Nicole, but I've seen in the OCD world that OCD providers, they're more often the ones that are also treating tics. I don't know if you notice that too, but it's just kind of a interesting constellation of people who are treating OCD are often treating BFRBs or body focused repetitive behaviors, also Tourette's and some different things. So one of the things that you could do is, since that's a common skill set, I guess, for these people, you could go to the Tourette Association of America and look at their provider list. You could also go to IOCDF, look at their provider list. And as you see names being cross-referenced in both of those are probably going to be the people that you want to go after, because to be on those lists, typically they have to have additional training, more certifications. And so they're not just going to be somebody who says, oh, I work with Tourette's, but have just really maybe read a book about it, or theoretically, I'm air quoting, know about it, but they actually know how to treat it. So I would probably cross-reference both of those places and really nail down some names. And with SciPact now, there's a lot of providers. If you don't have anyone there could be people, psychologists right now, social workers are almost ready to pass their version of SciPact where you can cross state lines in terms of your licensure.
Right.
But that really opens up a lot of opportunity to have more special clinical treatment.
It does. And I'll say for international fans, the SciPac psychologists, they can treat over lines. Also, there's Compact that is supposed to allegedly allow providers like Angie and I to be able to work across state lines. And for you, Angie, where you're located, for people unfamiliar with the layout of Indiana, which I don't blame any of y'all, Angie and I know it well. So does Lindsay, I guess. But she's very close to the Michigan line. And so you can think about if you're licensed in Indiana and someone is, a mile away from you, but over the line, how upsetting that can be when you really need some hope. And so what I would add to that, and again, I'm not an expert in tics, but I will say I came late in the game to understanding OCD because I had a different specialty before OCD, and it came out of being open to learning. And so if you find a provider and they're like, I don't know shit about tics, pardon the shit, but if they're like, I don't know about that, then ask if they're open to learning about it. Because the reality is, whether you can identify it between Sydenham, am I pronouncing that correct, Korea?
Yeah.
And tics, like say, are you open to learning about it? Because if they are, maybe they can help you advocate and find out more information. And wouldn't that be great as a parent who is already exhausted and trying to put out fires constantly?
Can I say something real quick?
Yeah.
Just because it tags so well. That's what happened for me. I didn't start out PANS PANDAS therapist.
Yeah.
They literally came knocking on my door. And so that forced me to learn more about it. And there's just so many in our area.
Yeah.
And nobody was talking about it. Nobody knows about it. So it came looking for me. Lindsay?
Well, and that's exactly the point that I was about to make, is that it is very important. You guys, I know all the ins and outs of the LCSW therapy world, but as a parent who talks to other parents, it's very important too that whoever you are seeking out not only understands OCD, but truly understands PANS PANDAS and childhood presentations of OCD, because there is a pattern to OCD in PANS PANDAS children where it will wax and wane with infectious trigger. And there might be an application that would be very appropriate for OCD that is caused by one thing versus OCD caused by PANS PANDAS, because the inflammation on the PANS PANDAS side, if you did exposure therapy, because that's what your licensed clinical social worker or your therapist knows to do for OCD, but they don't understand PANS PANDAS, you could actually make it more traumatizing for the child. And I know Angie and Diana could probably speak to that with more eloquence, but that is a very important thing that I tell people it's not enough to just understand OCD. You have to understand the dynamic between the PANS, PANDAS, and OCD. And just one more thing I wanted to say, because as a parent, trying to put myself in a position of a parent learning everything, drinking through the fire hose right now.
Right.
If they're anything like me, they're going to do their research. Their journey through PANS PANDAS has taught them so much about the need to come into every single appointment you have equipped with as much as you know yourself and not depending on other people for the answers, because they've probably been through a dozen doctors before they even got the right diagnosis to begin with. So from a perspective of a parent who likes to do the research and likes to know so that I can ask all the right questions, I did want to mention, and maybe we can put this in the podcast notes, but Angie's done some amazing work. She's going to be too humble to say it, but she's done some really amazing things for not only PANS PANDAS patients, but for even therapists who are trying to better understand OCD and what that looks like. And I know on her website, she has available to people these OCD webinars that really help parents and professionals both to better understand, okay, yes, I know I need to find help. Yes, I know there's a 6-month wait time for a quality therapist who can understand PANS, PANDAS, and OCD, but what do I do at home, like now? How do I understand this myself so that I can have a conversation with my child and help them to know that this is something happening to them? To Diana's point about giving them something to hold on to rather than something is wrong with me. And my parents just keep asking me questions because parents don't know the questions to even ask. I didn't know 7 years into Brady's journey, half of the doubts and what people sometimes would call intrusive thoughts, I had no idea because I never knew the right questions to ask. So I would really strongly suggest that people do visit Angie's website. It was a tremendous help to me. And I share that resource to a lot of other people whose children have OCD and don't have PANS PANDAS. It's just really helpful for parents to get an understanding of there's more than one way to handle this too. And you need to find somebody who knows PANS PANDAS. I'm sorry for the long thing, but that's kind of important for me to have parents know.
Thank you for saying that. That was super.
I'm serious.
Angie, you are our unicorn. You are. They exist in the wild, and she is with us today.
I'm sparkly. I've got my Parisian hat on here.
I know. You look fancy and your skin looks flawless, and I'll just say that. Okay. And, part of the reason why we're having this Q&A today is exactly what you were just saying, Lindsay, is whether it's drinking out of the fire hose or not even knowing, like just being in that fog of like, what do I ask? You don't know what you don't know. None of us do. And so part of the usefulness of this is not only getting and hopefully fielding some answers or some food for thought, but helping people that are just completely stuck and just in the trench of it all going, oh, I didn't even think about that. Being able to think together because we're better together. That is the whole thing, you guys. We are better together. I'm actually going to skip on our list because I feel like it goes along with what we were just talking about. Has a lot of details that I don't necessarily understand, and that's why I have the panelists. Yay! So the question was, has anyone experienced Sydenham chorea? My 7-year-old recently started moving strangely, and it is super similar to Sydenham chorea, just not as drastic as the few videos I've been able to find. Which goes to say, sometimes when you're looking for content out there and going, who else has experienced it, it can be extreme, and you go, oh my gosh, is this where I belong? Because people tend to not post and go to forums and create videos over milder content. They show the extremes. And so that's where you're going to find your echo chamber. There isn't a lot of information out there on it, let alone for a PANS child. We saw her PANS doctor who ran some labs. We're waiting on those. He agreed they look similar, but has no experience. Oh gosh, that's a loaded one, right, guys? He's the PANS doctor and has no experience and didn't know how to treat.
Can I just say there are many papers on how to treat Sydenham chorea, so that's just no excuse. Anyways, keep going.
Yeah.
There's many papers.
So this mother, I'm guessing it's a mother, it could be a father, but we saw her PANS literate neurologist as well, who agreed it looked like chorea, but said that nothing can be done. So we know that's bullshit because we just heard that, right? That's right. I'm using the cursey words today. We get fired up when it's parent time, right?
Are we allowed to swear?
Oh, you are allowed to swear.
Don't let me start.
Here's the thing. I make no limits on language because OCD makes limits on everything. And I'm like, screw you, OCD. So we, no matter what, it's all welcome. Yes, you are welcome here. Okay.
I love that.
This kiddo is on prophylactic penicillin. The doctor said if it gets worse, they can try a medication for tics. He also said if they wanted an MRI, they could try that. Does not sound like this doctor is really helping that much. It's almost like an ER doctor, which no slamming against ER doctors, but it's like such a generalist answer. And so also they wanted to test for Hashimoto's encephalitis, which is thyroid related. Hashimoto's, for anybody familiar, is an autoimmune disorder of the thyroid. And Wilson's disease. Have never heard of Wilson's disease. Y'all know what?
Copper.
Okay.
Too much copper.
Too much copper, of course. Copper. Okay. And the doctor doesn't believe in Hashimoto's encephalitis or copper.
I think she should find a new doctor, but
Yes.
just saying.
Yes. So he basically ruled out, too long don't read, it's not seizures. This was not a helpful response for this poor mom. And this little 7-year-old, I can only imagine just how tough this has been. So we know that it's BS, that it's not treatable, especially when we're talking about Sydenham, Korea. But anything else you guys would speak to this beyond get a new doctor? Because this guy is not doing it.
Are these like real live questions like people asked recently?
I can't say like how recent because I don't know. They're randomly submitted. But yes, they're real live questions.
I'd be happy to talk. But look, the easiest way to treat, to calm chorea down is with prednisone, an oral steroid or an IV steroid. It'll calm things down a bit, and then it'll buy them time to look at the literature that you can Google on getting better from Sydenham chorea, which often includes IVIG, lots of times, most times, bicillin shots, intramuscular shots of the penicillin. It gets in there faster and it's a little bit more sustaining, sustains better, and doesn't have to pass through the gut. You know, when you take a pill, it goes through your tum-tum. So it seems to work better. And then if it gets really, I guess maybe the big thing is if that child keeps getting strep, it will become worse and profound. And they're going to need plasmapheresis or something can develop. What I'm seeing with people that have Sydenham chorea in Europe is they're developing what's called chorea paralytica. The little children's chorea becomes so profound that they have to be on wheelchairs.
Wow.
They can't walk anymore. So she needs to do something to stop the onslaught from strep. And steroids are a beautiful way to calm things down. Or just go to the grocery store if you can't get steroids and get some Aleve. Do it 2 or 3 times a day. I'm not a doctor, so I'm not supposed to say those things, but it's just anti-inflammatory.
Yeah.
Really.
I ultimately think that there's overlap in all of the things that they're looking at in that there's inflammation systemically to blame. And to Diana's point, I will say I know doctors that mean well and they really like I respect that the doctor said that he didn't know how to treat it because I'd much rather that than a doctor laugh in the face of this woman.
Right.
So I see this as a very typical thing that people come across. And I could not agree more with Diana that, okay, they might give you a medicine for tics. Maybe it'll work. Maybe it won't. It's a Band-Aid. So you're not getting to the root of the issue. So find somebody or, you know, maybe that doctor could maybe refer you to somebody who does better understand Sydenham's chorea, somebody who does understand how inflammation can create these body movements, cut to the very core. I mean, Diana, I'm also not a clinician, but like my question would be prophylactic penicillin. They put my son on a treatment dose of Augmentin for 30 days when he was diagnosed, and 3 days later, we saw improvement in him.
Yeah.
So maybe you change the group of antibiotics. There's many ways to develop the appropriate sort of like cocktail or treatment for each child because each child's going to be different. Each family's going to be different. They're going to have different comfort levels. It is not a one-size-fits-all approach. But if you feel like you're not getting answers, reach out to Diana, who's the executive director of the PANDAS network, message them. Diana, maybe you can tell like people where to email. Reach out to other parents who might have similar situations and start asking for some other experts. You'd be surprised how many people you can do things remotely with once you establish care too. So don't confine yourself to your local area.
A quick question, though. I mean, I'm guessing if they were on prophylactic penicillin, that they were at least acknowledging some kind of inflammation, right? But at the same time, because I know one of the things, at least here in the States, is especially if you've recently been on an antibiotic and you will hear a lot of different pediatricians and general practitioners, family doctors say, oh, well, we don't want to overprescribe antibiotics. They were just on an antibiotic. this is going to render it ineffective. We need to do something else. So it's tricky because sometimes your doctor.
I actually agree with that. I actually agree with being careful with antibiotics. And I think that parents do overuse antibiotics. You do need to do a real thoughtful consideration of what's going on in the family. Is there a lot of strep? Are the tonsils inflamed? Could you do a steroid in addition? We experiment with getting the inflammation down. It doesn't have to always be just antibiotics. I
Yeah.
mean, come on. So, antibiotics are life-saving all over the world with people who do have Sydenham chorea traditionally comes only from strep. So, I mean, you need to see infectious disease. It was infectious disease that helped me understand my son's illness many years ago. It's 18 years ago. And he said, Diana, here's your azithromycin. The child is going to be on this prophylactically for 5 years. I almost had a heart attack. I was like, what? I was outraged. And he said, no, no, no. He goes, when it's a really bad infection or it's a really bad infectious process, the danger to brain injury, is more important than what's going to happen to his tummy over 5 years.
And they
So,
have a place. Like everybody's different,
there's a
and that's
place,
why you
yeah.
have to have a conversation. So, like for me, I can
Right.
tell you right now, I don't know where we would be had we not done a burst of Augmentin for 30 days, twice a day. I think I would have rathered that than be on Augmentin. Let's say we delayed treatment, he was worse, his baseline continued to rise, and then we're looking at a whole slew of other things. So I certainly am not saying, oh yeah, antibiotics is the fix, but I'm saying find a doctor who will maybe look at like
Think
how
about it.
and
Yeah.
collaborate with other doctors to say there has to be another way to address the inflammation. And unfortunately, at this juncture in medicine, the parents are pioneering and driving a lot of those conversations. They're not making the clinical calls, but they're asking the right questions and they're seeking out the right doctors because they're talking to each other. So talk to other parents. There's so many resources. Take advantage of them because there's no use in letting time draw out and watching your child get worse and worse because the people that you've typically gone to don't really have a plan.
Yeah, that's a really good point. And I would say, I would imagine, just trying to put myself in a parent's shoes of that situation, it's hard to know when to keep pushing and when
Right.
to accept, like, yeah, this isn't going to be better by me pushing antibiotics. It's hard. But I think what's most key is that you feel heard and not shut down by your doctor, right?
That's nicely put. Yeah.
Yeah. Yeah. So if they don't believe you or they are shaming, next,
Right.
next.
So I was going to say, from a scientific level, the only group that is looking at why infection makes the body or the mind go wacko or have difficulty is at Columbia. In terms of the deeper science about how this happens, what makes neurons malfunction, specifically how it irritates the brain. It's only Columbia University currently doing that work specifically for our children.
Yeah. This
Um,
would be a good place then to talk about the slides.
Yeah, could we go to the white slide first?
Yes. There we go.
So this is not something for anyone to memorize, but we're always wondering what's happening in the children's blood that's making them flare up. And Columbia's been able to show that children that have PANDAS or PANS have very inflamed cytokines or T cells, the same thing that you get in IVIG that's calm and helpful, calms down all of the things that are in the blue areas. You see the blue, that those are the PANDAS kids are in blue. Healthy children are in gray on the left. So the PANDAS children's blood is highly inflamed compared to the kids in the gray area. And then you'll see, you were talking about mast cells. The cytokine profile in the middle, it's a CXCL10 on the left. Then in the middle, it's GMCSF. That's another name for mast cells. So the children that have PANDAS have very, very high GMCSF or mast cells. Healthy controls have none of it. So this signature should be a blood test one day for children. We just don't have a donor to create it in a blood test. We do know what cytokines are out of range. No one's testing for this yet. So then what do those cytokines do to the brain? If you could just go to the next slide.
Sure.
So on the left, you see on the bottom left, it says voltage next to the green. That means that the voltage in the brain of neurons and how they fire. So on the left or on the purple is blood of just regular people who are healthy, regular children. And on the bottom left is their neurons. And you'll see these squiggly lines between the neurons. They're firing and they're happy. In the middle are some controls that Columbia used. They're healthy too. And you can see the little squiggly lines. They're doing great. And on the right are the PANDAS kids' cytokines, the same ones that you saw on the other slide. Their blood cells have these really fiery cytokines that are exciting everything and creating inflammation. And what happens is, if you look at the green down beneath those kids, there's no squiggly lines between the neurons. They're not talking to each other. They're short circuiting. So the blessing of this research, nobody's seen this yet. Just about 60 people have. We'll try to publish it. Dr. Tan will at Columbia, Dr. Agayu at Columbia will publish it. But we'll have to do an education campaign to help doctors know that the blood is injuring the brain. The inflammation is there and it's making the brain not communicate properly.
Mm-hmm.
And there should be rapid improvement if you can calm down the inflammation. There's no brain damage.
Yeah.
No brain damage at all. So I wanted to share that inflammation is the key.
Yes.
Bring it down.
Well, and 60 people plus the fam have at least some open awareness because Diana was able to walk us through that. And thank you to Columbia. We will be having a little more information on that study and the research going on over again at ocdfamilypodcast.com on this episode's blog. So yeah, I mean, that's really exciting. I was just thinking, isn't that just the story though? Education campaign. It's about the education campaign.
It is.
Yeah.
It really is. And I see in Europe, just real quick, America, man, we have our problems here. We do.
Mhm.
But people can do what they want to do. But in Europe, I'm just going to say it, I hate to say it, but the United Kingdom, some of the Nordic countries, they absolutely do not help parents and they are not allowed to question the authority of their doctors. So they don't get any help at all, really.
That's problematic. It's interesting because I think, and I'm going to guess it's from somebody outside of the UK, put something about like, why is the UK ahead of us? But I think it was in response to an initiative where people were starting to outline. Actually, I'll just jump to the question.
The UK is not ahead of us at all. It's not true.
You're like,
Not in any way.
you're like,
Not
yes.
true.
UK clinical guidelines for PANS and PANDAS are starting with a new initiative. What about other areas of the world? How do we fight for this when doctors are ill?
No, that's what we are.
Yeah.
We have created the guidelines. And it's a tiny country. So each of our states are doing initiatives. Well, not each state, but many states have parents who gone to legislative houses and are creating review committees, and insurance coverage is beginning to occur gradually across the United States.
You know what I think it points to, and I don't mean this in a condescending way by any means, the just desperation for more information. And you can look around online and you can see, well, this has got this going and I'm still in the dark here. And so it may
Yeah.
seem like other areas are way ahead when really we're all kind of clamoring to increase this education campaign and awareness campaign. Lindsay.
So this is very, very typical. I think that it's important to acknowledge, and I'm sure that this is true of our OCD family we're speaking to right now, pandas or not. It's a lonely place to be. And you feel like there's no way, like everyone goes on living their lives and you're like trying to explain to people what's going on with your kid and why you can't do the things you used to do. And it's just so much, right? And I think this is where I want to acknowledge to parents. I'll just do it with a story. I am working with a family right now, and they are newer in terms of they are on the first part of their journey in treatment. They've been diagnosed. They were diagnosed by a doctor who understands what PANS PANDAS is, but does not feel comfortable having any opinion because she takes her oath of do no harm seriously and does not feel like she's equipped to do that. And they have since sought out from other parents advice in terms of great clinicians to see for PANS PANDAS. And so, you're seeing a specialist, but you're also living in the day-to-day. And I want to say, we fight for this when doctors are ill-informed by treating our kids and by talking to other parents and by asking questions and asking for other alternatives when we are given information that doesn't sound right or following our parent gut. I had a family that we are working with that said, my family had strep. Luckily, my son didn't show any symptoms of it. But ironically, his hands and his feet started to peel. Have you ever seen them? And I said, yes, go get him tested for strep. My child's feet peel sometimes when he gets strep. And I've seen a lot of other parents say the same thing. She went and got him tested for strep. He's positive for strep. She was beating herself up because she would not have had him tested for strep. And I said, you're doing not only your son a huge favor by learning new things and being open to new things, but you went back into the doctor and you asked for a strep test, regardless of the fact that there were no symptoms of strep. And your doctor was kind enough to be open to you and did that. And because that strep test came back positive, she will now know for the next patient who comes in or the next PANDAS patient that she sees that she knows has it. She's learning from your educating her and from her having the ability to collaborate with the specialists that are willing to talk to her about your son's case. So I think a lot of it too, I mean, it's not just policy or top down type of things, but this can be very much a bottom up education where our experiences, I mean, one day I think we're rewriting history to some degree where our experiences and the way we're pushing for our kids and the way that we're getting legislation passed, that's going to help the next generation when they're like, oh my gosh, could you believe that at one point they did not realize that infectious triggers can cause neuropsychiatric issues? So own that. Like as a parent, I think it's a great opportunity to pay it forward to the next family too.
That's a great point. Yeah. 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 And as with anything where we're trying to fight stigma and increase education, I think that's just part of it. It is that bottom up approach. And people learn. I can say that's how I learned about OCD and then expanded into training and learning more. And it sounds like for Angie, that was a similar road with just working with PANS, PANDAS, and tics. And it's a really great point, Lindsay. I appreciate you sharing that. In terms of strep, it made me think of another question I saw. It had a very interesting form. It talked about vaginal strep. And I was like, what? I'd never heard of that.
Little kids get it on their bottoms and their private parts.
Look how much you guys know and how I'm learning.
And you know, grandma or grandpa, if they have psoriasis, that can be guttate psoriasis. That comes from strep.
That's very interesting.
One of our patients that we help, her brother constantly has impetigo, and that's a form of strep on the skin.
Oh,
and the mom never made the connection until PANDAS was on the scene, and they were continuously exposing her to strep. And so then the Th17 cells respond.
Yeah.
Yeah. I just say that as a cautionary word, Angela, I'm not sure what you'd say to patients, but if strep related issues continue, if people keep getting strep, if 7-year-olds get strep when they're 7, 8, 9, 10, and they keep getting that assault, thank God it's a fraction of our world. There are people who can't handle strep. It will cause permanent mental health issues. It will.
Mm-hmm. So you clarify something though, Diana? Because you said when we were talking about the slides that there's no brain damage. So how does it cause permanent issues with, are you talking about untreated or what?
Right, untreated.
Chronic.
Okay.
Because we're talking about chronic then.
Chronic strep.
Yeah.
There are some people who I talk to have it 10 times in their house a year and continue to get strep until they're 25 years old at the rate of 5 to 7 times a year. There are those extreme cases. You know, I hear those cases. And
yeah, it's very fascinating to see how that impacts, but also what we know about child development is in the 0 to 5 years and in that early adolescence and going into emerging adulthood is the biggest period of brain growth. It's part of the reason why like Dare to Care campaigns and don't do drugs during periods of huge brain growth are so important because you sit and you go, well, this is when you have the most neuroplasticity in your brain.
And I have to say, you know, there's one doctor, his name's Earl Harley, he's an ENT at Georgetown. We're finally realizing that he and other ENTs have been against tonsillectomy, like really kind of adamantly against tonsillectomy and giving a damn about strep. It's kind of been a whole approach for the last 20 years. Less tonsillectomy, 6 consistent strep infections within a few years time span, then you can get a tonsil surgery. So we're just trying to open the awareness amongst doctors that strep sometimes can be very dangerous for some people. Maybe our kids are 5% of the whole population of the US, but sometimes surgery is needed and we need to not be so conservative with the guidelines. It's going to be a fight, but part of this mess is because of the lack of strep awareness amongst doctors anymore. They don't care that much about it anymore. They're not worried about it. And the lack of tonsillectomy. Guidelines change.
One thing to add about tonsillectomy, Diana makes an awesome point, is a lot of these children, I was told by a leading neurologist, a lot of these children have unremarkable tonsils, meaning they go to an ENT and the ENT's like, oh yeah, your tonsils are tiny. They don't need to be big to be dangerous. They don't need to be big to have strep encapsulated in them. They do not need to be big to be sending a signal to your body to circulate the Th17 cells that fight the strep. So big tonsils does not equal need to remove, and small tonsils does not equal no need to remove.
You have to have an ENT just who's willing to talk to you about your child. I mean, I would say this. My daughter, Caitlin, had one strep infection and developed PANDAS, and I never took her tonsils out. She's 19 now and doing very well, but I don't want to get too deep into her, but she's relapsed 3 times. And I often think it's because I didn't take her tonsils and adenoids out, but the science isn't very clear on the unremarkable tonsils yet. So you really have to have better conversations than I did. I didn't have good conversations with an ENT about her at all when she was 7 years old.
Well, and I think an analogy is a lot, and one of the parallels just to what you were describing, Lindsay, reminds me of breast cancer, right? Like you can have very little breast tissue. You can be male and have very little pectoral and breast tissue and still get breast cancer. And so it's a misnomer that only women get them or only women with a certain size breast are at risk for getting them. And it's not exactly the
That's
same.
a good point.
Yeah, yeah. And so if you've got tonsils, they have the potential to be infected no matter size, no matter what form, no matter, right? And that goes to also say it's important to point out that just because you get strep or just because you might get an infection doesn't mean you're going to get PANS or PANDAS either. Particularly.
Absolutely.
Yeah.
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 Thank God.
Yes.
Okay, my other add-in is talking about ENTs. Again, find a PANDAS parent community that you can tap into to get recommendations to vet your own people, because it is really helpful to have an ENT who understands PANS PANDAS. Yeah. I fear that sometimes people go to doctors that are very dismissive of their concerns. And I just encourage you to advocate and ask hard questions.
And we have on our website, the pandasnetwork.org website, and people can email us on our website. It says email us here. So you can send an email on there. Sometimes I'm a little slow at getting back, but I have other people who help me. But it takes a little time sometimes. But if you say urgent, we'll know it's urgent. But anyways, if you go to a doctor who doesn't believe you, under clinical research, we have a great video about really hardcore research, which is what that neurological stuff was that I just showed you. Doctors haven't read it yet. They haven't read it. And it could buy you some time and some dialogue with an unwilling doctor or a doctor who's negative.
Yeah. I mean, it's, again, you can show them the research. I will say specialist field, and this can happen in the OCD field. I feel like overall, our OCD field tries to be pretty good about this, but in any specialist field, you can go in and if you say, well, I have this research, sometimes they look at you like, aren't you cute? Trying to teach me. I actually have a medical degree, but thanks for your forum research. And to that point where, Lindsay, you were saying being able to find your tribe, and there's so many resources out there for parents, sometimes doctors will be dismissive of, oh yeah, did your parents say that? But you know what? Parents are living this and they've crossed a lot of bridges. They know what is leading to something and what's leading to nothing. They know what tests to look for. They know which therapists, you find one therapist like Angie the unicorn who is amazing. And you're like, everybody talk to Angie, which Angie only has so many room and so many openings. But just even having those resources available on the website are so important. Also, if you can find an open therapist, you don't have to make those calls alone. Sign some releases of information. Let your therapist go to bat for you. A good treatment team doesn't mean you have to do all the work, mama. You have to do all the work, dad. It means a good treatment team, and they team together and they split the load, right?
Right. And the happy news, like we made the name, it was me and some other moms. We made up the name Pandas Network many years ago because we would just had a phone tree and we were so scared. We were so scared. It was all local to Palo Alto area. And we created this network, a phone call that we'd call each other every morning, 4 a.m. or 6 a.m. How's your kid? How's your kid? How's your kid? So we just kept going that way. And it's so neat that there's the internet now to communicate. But the field of psychoneuroimmunology, how the brain is attacked through the immune system, will grow and grow over the next 5 to 10 years. And every parent listening today, you're going to be the pioneer. Like Lindsay was saying earlier, we are the pioneers and we need to stick together because the doctors do need us to help out probably in the future with other children. The research is brand new and the equipment is getting really, really good now so that we can measure, a couple hundred kids at one time for these immune cells. It's just taking time to get the funding to be able to get the 100 kids together to measure their blood. In time, we'll organize all of that. It will happen. I'm sure of it,
It's a really great point.
but it's not now.
It's
It's not ready yet.
It's not ready yet. Yeah, I like that word yet, Diana. It's a well-placed word because that means it's in progress. And like
Yeah.
Lindsay said, one day we'll get to say, hey, remember when we were so naive to this point? And
Boy, will I be happy, man, when that day comes. Woohoo!
yes. Well, and Angie, much like in our OCD specialty, right? It's like when doctors are going to school, they're not getting taught on this. And this is such emerging research. And we're not taught on OCD either. So if you find an OCD specialist, it's because they've taken the time to go earn some extra education, do some continuing education, do some training around that. And so it's difficult because you go into your run-of-the-mill therapist, they're not going to know about OCD. You go to your run-of-the-mill doctor, they're likely not going to know about PANS and PANDAS. It's really, once you encounter it, if you are having the openness to learn more and you see the dynamic need and decide to specialize in that, that's really how some of these doctors are coming about. And so it can feel like the weight of the world, like, oh my gosh, there's so much room to go. But also, look, there's a mighty, mighty group of voices, and there are no voices like a mama voice or like a caregiver voice saying, nope, we're going to need better for our kids. Nope, this is not the quality of life they deserve. And we're going to fight for the return of the person I once knew and I still love. So do not give up hope, fam. If anything else, do not give up hope. Now, we were talking about tonsillectomy. I talked about also the surprise to me and learning that strep can show up in private areas like your vaginal area. And so I'm going to cut to this question because I think it kind of piggybacks on what we were talking about. This question talks about pandas flare when I'm presuming kiddo has a pandas flare. Often they will see that OCD happen. And so an example that they will see in their daughter is she will go to the bathroom and immediately ask, even if she just went or asked for reassurance, does she have to go? Does she not have to go? And it's so hard and heartbreaking, but that's one of the ways they know that flare is happening. For this kiddo, she's already had her tonsils out, and so they're suspecting it might be vaginal strep. And they're asking any tips besides ibuprofen antibiotics if she tests positive, because ibuprofen seems to help a little bit, but she also gets very aggressive and clingy and her sleep starts to suck. Now, I know we're not medical doctors, but what I will say is, and Angie, I'll cut to you first as a therapist in seeing some of these flares and treating them in clients, what would you recommend for this treatment course?
I'm curious. The first thing when you started to read that is that sounds pretty common in like sensory motor OCD kind of stuff too. So I would be curious if this kiddo has other OCD. And as Lindsay mentioned earlier, so many pediatric OCD symptoms, parents don't know that it's OCD. They just are like, oh, and the kids certainly oftentimes don't know that it's anything different either. So the first thing that crosses my mind in this is if they just went to the bathroom and then they're questioning, do I still need to go to the bathroom? That's a distrust of their body senses. That's a distrust of what they know to be true about their body, right?
Yes.
So that feels OCD-ish to me.
Yes,
So
it does.
yeah. So I would be questioning and maybe doing the SciBox symptom checklist and educating the parents about what OCD looks like in kids and see if there's other things going on too. Of course, us social workers are taught to rule out anything medical. So we would probably want to look at the medical pieces. If the OCD is sudden onset, then absolutely I'd be looking for some help with, is this a flare? Is there strep? Was there strep? All those things.
Yeah, I couldn't understand if the person was asking, is the strep coming back again? I didn't understand that
I think
kind of.
from my read on it, and it's supposition, but from my read on it is maybe it's vaginal strep. And I think maybe they're connecting that because of the bathroom urging. But what I would say, because certain people are going to be more prone to this than not, and I was talking about this with Dr. Melissa Hunt on a recent episode about IBS and some of the GI symptoms. If you've been on a high level antibiotic, you might be more prone to getting something like a UTI. If you had a UTI, anybody who's ever had one, you might have that sensation of I just peed and I feel like my bladder didn't empty and I have to pee again. It could be symptomatic of that. And so, while it's great to also have that medical check, like you said, Angie, we also know that sounds very consistent with some of the OCD. And she used the example of the bathroom, but it sounds like when this kiddo has flares, she sees that huge uptick in OCD symptoms. And so I would guess
I
that it has to do with that.
They might want to stop the flares.
Well,
Yes.
I would imagine they do want to.
Well, I mean, there's ways to do that. So,
If your kiddo has vaginal or anal strep, you are definitely going to know. I had one of my little guys, I have not three little boys anymore, but when one of them was in preschool, the preschool called me and they called me very concerned, like, leave work, you have to come in now. And they basically thought that something had happened, air quotes again, to him
Mhm.
because he was complaining of such a sore bottom. And they looked and it looked so catastrophic that they thought that. And when I saw it, I thought the same thing. And so, I had to immediately take him to his primary care, urgent care. I had to have a note releasing him saying that it wasn't what they thought it was. So if there's vaginal or anal strep, you're going to know. It's not going to be a question. I wonder if something's happening. You're going to know something's happening down there. It's not going to be a curiosity.
I think what I would say to this parent too, to add to what these ladies have said, is that we have to remember how PANS PANDAS works once the mechanism, so to speak, has been turned on. So anytime that my son and a lot of these children have any spike to their immune system at all, they will have an uptick in inflammation. And so they will have an uptick in their PANS PANDAS symptoms and their flares will come and go. It does not need to be just strep. So for example, my son, if he were to get the Epstein-Barr virus, I know every flare is different, every child is different, every trigger creates differences. Nothing is one size fits all. But if my son got the Epstein-Barr virus, the flare would look very different than the flu shot. Or other things can cause this flare. And the fact from my experience that the daughter's compulsion is to then check in with her parents and say, can you reassure me that I don't have to use the restroom? That tells me that probably OCD is more likely what's at play here. But because there's an overlap in the area where the OCD is fixating on that sensation, maybe making them think vaginal strep. But I encourage people to think outside of just strep and realize that once you have this condition, any spike to the immune system, including losing your teeth, having dental work done, getting other viruses, other environmental triggers like allergies, that can all create this waxing and waning of symptoms. So don't keep your thoughts to just strep. And also remember that she's looking for you to tell her that she doesn't have to go. That's probably an indicator that there's some doubt of trusting her own senses, like Angie said.
Lindsay and Angela, I don't know you guys well enough, but I feel like what's been conveyed is that it's okay to keep relapsing and remitting for years and years. And it's really not true that it's okay.
Mm-hmm.
So, I mean, I feel on the forums that I see amongst parents especially in Europe, they have no choice often, unless they fly to the US, that people allow this condition to continue from 7 years old to 12 years old. It shouldn't.
It's treatable, right?
Yeah. So I just wanted to make sure that people understand that it is treatable.
It doesn't have to be chronic.
Right. Well, and that's a huge piece that we want to emphasize. And speaking to that point, Angie, you work a lot with how to manage and how to even reduce these flares. And so would love to hear more information that you could share with the fam just regarding your work around these flares.
Yeah. So I've got a lot of things I could probably say about this, but one thing is when these kids are in flares, they are going to require a different kind of parenting than when they're not in
Mm.
flare. And so we have to kind of keep our eye on the goal and the thought of what's the assumption that parents or caregivers are having about the behaviors that they're seeing. You know, is it looking to you as a parent as a lack of discipline? Is it a lack of tools and skills? When it comes down to it, this is inflammation. So it's kind of like if a kid doesn't have a tool or skill in the moment that they can use, a lot of people are learning from Becky Kennedy these days, and she's a great resource. But I heard her the other day talking about when kids don't have tools and skills, they have to learn them, obviously. So we wouldn't, as parents, give a punishment or a consequence for a kid that doesn't know how to swim. We wouldn't give them a consequence for not having that tool yet. So what would we do? We would teach them how to swim so they have that tool or skill.
Mm-hmm.
When these challenging behaviors come alongside of a flare, there are so many things that we can do to help them. One thing that I do like to use is Ross Greene's collaborative problem solving approach. And I find that as something that's super helpful for parents and the kids alike. And there are kids who can't even come into the collaborative problem solving approach yet because their emotional dysregulation is so high and their nervous system is so overactivated and their feelings are kind of like on sunburn, if you will. So
That's a
lately,
good way of describing it on sunburn. Yeah.
yeah, it's just they're overactivated and their fight, flight, freeze is on high alert and it's false alarms. But for them, it doesn't feel like a false alarm. It feels like a matter of safety. And so, one thing that I've been diving into is the world of PDA. So, PDA, for those who don't know, it had a horrible name, to be honest, but we can't change the name.
You know what,
But
though? Let me stop you there, Angie.
What?
Some people, especially within the autistic community, are like, don't you come after my name. I wouldn't.
No.
The name does sound pejorative to
It's
some,
hard.
but other people really love that. Just thought I would say that.
True.
But yes,
So
I'm
there's
sorry.
two
Go ahead.
different names. So because the acronym isn't going anywhere, PDA started out as pathological demand avoidance, and it's a profile of autism. People in the autism community have sometimes referred to it as persistent drive for autonomy. And that's a whole nother can of worms that we could get into. But I think there's some really great benefits for parents and caregivers to parent or caregive through this PDA style of parenting, through this profile of autism. And so when you're looking at PDA, sometimes people refer to it as low demand parenting and want to make sure that that isn't confused with no demand parenting. It's lowering the challenges that increase the nervous system overactivation. And if we think about it, when we've got these kiddos, they are so emotionally dysregulated because of all this inflammation happening in their brain. And so we don't want to continue to do things that are going to make that fight, flight, freeze activate even more. So we kind of want to bring things down. And again, this is when they're in flares. When they're not in flares, we're not going to see these types of challenging behaviors. And so we can go back to our typical method of parenting. But we really want to bring things down for these kids so that they're more able to access.
I'm sorry to interrupt you. I don't know who's listening here, but some parents themselves are very type A and really demand a lot of their kids socially. There's plenty of parents I know are not that way, But I don't know if this message would ever reach that kind of a parent on this podcast, but making your kids do competitive soccer and gymnastics and be in theater and dance while they're having pandas and then go to daycare is just way too much, man. It's like a whole family system has to change.
Yeah.
It's hard.
Yes.
It's really hard.
It is really hard. Totally agree.
Can I speak to that too? Because what I will say, and my kiddos are autistic, and I don't pretend to speak for any autistic person, but I actually just posted on OCD Family Podcasts, I think Facebook today, a reel, and I will link it to the show notes because I think it's interesting. Yes, there are certainly the very high demand parents that go out there and have the kid in all the things and expect 4.0 or above GPAs and all the AP classes and all the things. But what was interesting is I saw this reel today and it talked about, and I think this is very consistent with the PDA research that's emerging as well, Angela, about what is high demand. And, in this reel, this woman was talking about, for me, high demand is taking a shower. My husband goes and takes a shower and that's relaxing and he takes his 15 minutes and it's just like a check of the box. She's like, for me, I have to think about like regulating the water and the temperature and how that's going to be sensory wise. And then actually getting in and starting it. And I'm going to feel cold when I undress. And that's going to be very dysregulated. And then I'm going to get in and I'm going to wash my hair and I'm going to condition for 15 minutes and do all this. And now I don't want to get out of the shower because it feels good. She went through like, in her words of like what can feel like 400 steps. And so then you think about the nervous system and going, I need to shower, but my nervous system is clamping down with 400 demands, whereas the husband is like, that's not a demand. This is a nice thing. It's a hygiene practice. What are you talking about? So high demand can look different. And Lindsay, it looks like you have a point you could add to that.
Well, and my point's really short and sweet, but it's something that Angie has taught me as we've worked together is curiosity or judgment. You choose. Because if you choose to be curious and you ask the question, suddenly what I assume is easy, you've now broken down into 400 parts that make it really hard for you. And I think that you hit a huge point.
We're either in a place of curiosity. If we're not in a place of curiosity, we're by default in a place of judgment. So we always want to be curious. What's making it hard for my kiddo to do X, Y, and Z? And as soon as we assume that we know, then we have a judgment about a can't versus a won't.
I have a lot. This isn't PANDAS, but let's be honest. I have a lot of adult autism in my family. And I think that really summarizes that autism and maybe PANDAS too. It's the judgment versus curiosity. I never thought of it so succinctly.
Amen.
And how do you operate with people who are highly activated mentally? I mean, I'm just going to tell you it's exhausting. And here I'm doing this PANDAS work still that, well, you have autistic children, Nicole. Don't you get tired sometimes?
I mean, to be honest, similar to probably saying you have PANDAS kids, don't you get tired sometimes? It's our normal. And so I don't know it another way. But the people that struggle with it the most are the people with the lived experience. They're like, trust me, you're exhausted. I am spent. I am spent. Right? Angie?
Yeah.
I can say out of my 3 boys, I have one that has autism as well. And when I hear clients in the office, parents talking about like, oh, well, that's not fair. It's not fair if I do what we're calling low demand. I'm calling it low challenge, low anxiety overload, whatever. It's not fair. And it is exhausting sometimes to do one form of parenting for one child and then another form of parenting for a different kiddo. But if we're talking about fair, then we're also saying that the child that doesn't have PANS and PANDAS is going to have to like the same food as their sibling. They're going to have to go to bed at the same time as their sibling. They're going to have to like the same movies. They're going to have to wear the same clothes. Like that's fair if we're talking about fair, but we're not talking about fair. We're talking about loving them in a way that they are able to accept and grow and learn.
Yeah.
And that's
Boy, we're
everything.
becoming highly elevated spiritual beings by having this life path, aren't we?
Yeah,
Yeah.
we are.
sort of
Absolutely.
a blessing in a way.
It's actually a huge blessing, I think. It's more about the education campaign because what I notice, whether we're talking about PANS PANDAS, whether we're talking about autistic folks or allistic folks, if we know what support needs we need to get through a flare or to manage a high demand task, it's not that people are incapable. A lot of people will mask whether they have OCD, whether they're autistic, and maybe when PANS and PANDAS a little more raw in their own space, but around strangers, going to try and suck it in to get through that experience, and then they have the complete meltdown at home, right? Because they're so spent from all the energy it took to keep it quote unquote together. And so actually it's learning the support needs. And in the case of PANS and PANDAS, I mean, anti-inflammatory can go a long way. So we could sit there and we can certainly look at the presenting behavior and go judgy judgy, why are you doing this? And you're manipulating the situation. But we also look at, oh my gosh, they have inflammation that if we were able to calm and get under control would make all the difference. It would make all the difference. And sometimes kiddos, and I know it's on here in one of the questions at the very least, can get put on some pretty extreme medications, antipsychotics, things where it's not necessarily needed, but we're throwing everything at the wall and seeing what sticks. And that has some real consequences when we talk about brain development and brain damage, even, right?
Because I think we just don't know what to do. And actually, so we're talking about, medications being thrown. And one thing that I think is important to talk about too for parents and caregivers is bringing your kiddos to therapy in a flare. Because you as parents or caregivers are going to try to do anything that you can to help your person, right? And sometimes when they're in the flare, that isn't the right time or best time to take them to therapy because kind of like, vitamins, we have like that, what's it called, like bioavailability or something. We may not have the ability to intake the wisdom in that particular moment of the therapy. And if the therapy that's supposed to be helpful is the thing that is increasing the nervous system overactivation,
Yeah.
then it's probably not a great idea yet. Again, that growth mindset word, right?
Right.
It's just not yet.
Right.
It's always the right time for the parent to go to therapy.
Yeah.
It is. I mean,
That's huge. Yeah. It's such a good point, Diana, because you're going through so much. If anything, like Lindsay was talking about drinking out of the fire hose, like none of us would like drinking out of a fire hose. Now add it for a consecutive amount of time, maybe years. Like, yeah, you're going to be fried. And there's certainly different examples within these questions where people are like, I honestly, I can't, I don't have any respite time for myself. And I love my kid more than anything, but I'm drowning in this. And so I think it's such a good point, whether it's OCD, whether it's pandas, whether it's autistic burnout. If our thinking brain is taken over by our feelings brain, to put it in simplistic language, then, try and talk to me when I'm real mad about something in a very rational way. I'm probably going to be like, the hell with that.
Exactly.
Right? So let's
Yeah.
get back to how to children, please.
I could talk to you guys every month. I hope we can keep doing it. It's just so fun listening to your ideas.
Well, and it just shows how much we're better together, right, Diana? Because you are able to speak to all the movement and all the growth you've seen since your kids were first experiencing these symptom presentations to it having a name to where we are now. And we certainly get to see it on the clinical side, whether it's just in an OCD presentation or just in us being curious and going, hey, there's something more to this. So yeah, it is. It's fascinating conversation.
Thank you. Thank you.
Yeah, and thank you. And thank you, Angie and Lindsay. This has been wonderful. So thanks everybody for coming back. Brittany, we are missing Brittany today.
She's going to Dominican Republic.
Yeah, Brittany, let me know when you have openings on your team because I would love to have a staff retreat to the DR.
I know.
Right? I think we're all like next panel in the DR, somewhere exotic and fun. But thanks so much for your time.
Thanks for having us.
Thank you. I'm glad to be on here. Thanks for having us.
Yeah, absolutely. Thank you for that. Okay, fam. Are we having fun yet? Brittany, I bet you are having fun. I mean, by the date of this broadcast, Brittany's been back from the Dominican Republic for a hot minute.
But we missed her all the same, and I really loved all the discussion we were able to create for you today, fam. So just a quick reminder, I'm going to have resources linked to everything I can over at this episode's blog at ocdfamilypodcast.com. Also, Lindsay recently published a podcast of her own about PANS and PANDA flares, and I believe there's at least one Facebook group where parent resources are also being shared. So I'm going to provide more details on that in our show notes, as well as some resources I've been sent by other panelists to make sure that you have all that information available too. But a special thanks to all of our parents, caregivers, and lived experience warriors that submitted questions for today's talk. We circulated a Google Doc for people to add and contribute, and we really got responses from all over the world. So thank you, because I think these discussions were so helpful, and hopefully not only for yourself, but for parents and families listening, or trying to listen while they are guzzling from their own fire hoses. Also, another special thanks to my amazing panelists. It is always a pleasure and an honor to have you, Diana, Angie, and Lindsay. So now that brings us to this segment, my intrusive thought segment, which is my application segment of the show. And I'm going to borrow a concept that I was reminded of from Diana when she was talking about the early days that ultimately grew into the PANDAS network. But I've also heard a similar line of advice back when I was in Mommy and Me preschool groups. And that is to find your 4 a.m., 6 a.m., 3 a.m. friends. For some of us, we have the most incredible family network, and whether we need to laugh, yell, or cry, they're there for us. But not everyone has a supportive and understanding network. And some of us may feel really isolated, completely alone, and like nobody gets it. But guess what, Mama? Guess what, Dad? Grandma? Spouse? You're not alone. And we all need people that we can lean on. Whether it's a bestie, a family member, another internet parent that is just walking this all too familiar road. Diana made the point that they used to get on the phone, scared, and talk through these things. But also with the internet now, we can get on and post, or send an email, or messenger, or snap, or DM. And my challenge, family, is whether we're talking about PANS, PANDAS, Lyme, mold, OCD, or OC-related disorders, also known as OCRDs, I want you to try and connect with at least one other person this week. Maybe an established friend, or maybe a new one. Name and claim it, family, because we all need that 4 a.m. friend. That whether you need to message them, or even, dare I say, flat out call, crying, broken, at 4 a.m, you could, because you're not alone. And we are a village. And even though this fire hose might feel like it's pressure washing away your hope and sanity, I promise you, you're not alone. So hang in there, fam, because someday we just may be recalling with our 4 a.m. friends that there once was a time when neuropsychiatric disorders, encephalitis, and OCD weren't understood. And we can also remember how we have always been and continue to be better together. Thank you for joining me and our OCD family community. If you enjoyed what you heard today, please like and subscribe to the OCD Family Podcast wherever you enjoy your podcasts. Did you find this content helpful? Please consider leaving a review. The more people that know they're not alone, the better. For more information regarding today's podcast, please visit ocdfamilypodcast.com and remember to join the email list while you're there. It will provide you with the most up-to-date information, resources, and the demo on the family chatter. Oh yeah, nothing says family like Angie, Diana, Lindsay, and me finding hope in community. That's right, I went there. And you can too at ocdfamilypodcast.com.